The subject now is prosthetic dysfunction. Initially, we're going to study how to distinguish a pannus from a thrombus or vegetations. Just a reminder, prosthetic valves substitute native valves, but they are not a normal valve. They are almost always abnormal and dysfunction when analyzed by Doppler. Then, for a prosthetic valve, normal is just a question of the severity of the regurgitation or the stenosis. When studying a prosthesis, Doppler has paramount importance, no matter if by transthoracic or transesophageal echo. A regurgitation as this seen here needs intervention, even if the echo image of the prosthesis were totally normal. Same thing will happen if we have a patient with an aortic prosthesis and a mean gradient higher than 50 millimeters of mercury, or a mitral prosthesis and a gradient higher than 10 millimeters of mercury. In such cases, the TEE will be necessary for better assessment of the possible cause and evaluation of the better treatment. Pannus fibrosis is a tissue overgrowth in response to healing and generally involves the sewing ring and initial part of the leaflet or discs, causing regurgitation or stenosis. To differentiate it from thrombus may be occasionally difficult. The form of the mass does not differentiate. Both may be round or irregular, thickened or thin. Both may be mobile or fixed. Usually, thrombus is bigger than pannus and may extend beyond the sewing ring. Pannus are denser, almost with the same density as the sewing ring, while thrombus has a density like the myocardium. Pannus usually occurs in the left ventricle side when an aortic prosthesis, and in the LA side when mitral. But some clinical features may help the differential diagnosis. The time from initial onset of symptoms to the need for reoperation. Thrombus usually is an abrupt happening with rapidly evolving symptoms. It usually occurs sooner after valve replacement than pannus, and the patient may not have an adequate anticoagulation. Let's see just two cases now as an overview of the problem. Next two classes we will discuss with more detail. This patient with a bioprosthesis presenting with a moderate prosthetic regurgitation, and apparently there is no thrombus, no intense calcification, but seems to have some restricted movement of the leaflets. There are some dense echoes in the LA side, extending to the orifice from the sewing ring. It seems to be pannus. Obviously, a transesophageal echo is indicated for better assessment. Here, a single tilting disc prosthesis in aortic position with a mean gradient of 42 millimeters of mercury. Then it's dysfunction. TEE does not show any thrombus. There is some motion of the disc, and right here, close to the sewing ring, appears to have a denser structure that is much longer than just the sewing ring, and with borders that looks like a little rough. Close to the ring, there is also a small round structure, very dense. Pannus usually occurs in the left ventricular side of the prosthesis. This is highly suspect as being a pannus rather than a thrombus. Now, let's see thrombus. TEE shows that it has a texture more like a ventricular wall. It doesn't have the same density as the sewing ring, and advances beyond the limits of the disc to the atrial wall. Pannus does not advance beyond the sewing ring and is much denser usually. It also affects the ventricular side of the leaflet, common with thrombus and unusual with pannus. By now, we can be almost certain it's a thrombus. Another TEE of a bioprosthesis with many thrombi, not only in the leaflets, but also on the left atrial walls. Watch its echo density, the same as the walls, then it certainly is a thrombus. It would never be a pannus with these characteristics. Another patient with a double tilting disc. TEE shows one moving disc and the other completely stuck in a closed position. There is an obvious thrombus at the closed disc and another in and out of view at the moving disc, both with texture like the myocardium. It is not affecting the atrial side. The clinical situation of this patient was typical of thrombus, and she had thrombotic therapy. I will present her case later. Another problem is those caused by endocarditis. In endocarditis, the presence of vegetations is relatively easy to demonstrate in bioprosthesis, but very difficult in mechanical prosthesis. In a bioprosthesis, the vegetation may be sessile, but most of the time some of their borders are mobile, what makes an important feature to differentiate from pannus or thrombus. Notice that it is not easy to verify this using transthoracic echo. Transesophageal echo is required, and obviously the clinical situation is completely different. TEE shows a perfect vegetation in this valve as described in the section about endocarditis. The zoom shows how the vegetation moves from the ventricular to the atrial side of the sewing ring. And remember that the M mode is very important here. M mode is characteristic, completely different from calcium, pannus, or thrombus. As shown in previous lecture, we demonstrate the two signs seen only in M mode due to its temporal resolution. Note here the aspect of a cloud, of a smudge, and the paper thorn sign. Another TEE with many vegetations. We see their mobile borders, and for sure the clinical situation of the patient is more important than anything to make a differential diagnosis here, not with pannus, but with thrombus. The long acts of this patient with an aortic bioprosthesis show this mass here, with an echolucent central area characteristic of an abscess. TEE showed this abscess involving the sewing ring and part of the base of the anterior leaflet. We see also vegetation in the prosthetic leaflet. We also see that the abscess continues along the right atrioventricular ring. In case of mechanical prosthesis, it is not as easy to identify a vegetation. Look at this case. One of the discs has a slower closing than the other. However, it starts opening before the other. This can be found in normal double tilting disc in patients with atrial fibrillation, as in this case. But the patient had a clinically suspicious endocarditis. Looking for endocarditis, we could notice these 2 points here that could be vegetations, though too echo dense, but we could not disregard the possibility of just stitches. Yes, it could be pannus, but this exam was performed only around 3 months from the surgery. Too early for pannus, but the presence of a severe prosthetic regurgitation and a paraprosthetic leak, which happens frequently in case of endocarditis, and considering the clinical situation, the echo diagnosis was very suspicious of endocarditis.